Good morning, good afternoon, and good evening, everyone from wherever you're joining us, and welcome to today's webinar titled, What Every Researcher Needs to Know About Using Medicare Data for Real-World Evidence, featuring 3 panelists who will provide a practical overview of why and how to use data from Medicare for real-world studies. I'd like to thank the sponsor of today's event, the Partnership for Health Analytic Research, or PHAR, for making it all possible. I'd like to now introduce the panelists participating in today's session. Dr. Eunice Chang is Vice President and Chief Statistician at PHAR. She leads many secondary data analyses and provides methodological and statistical support on others. Our second speaker is Mitra Corral, a principal health economist at Genentech, who has extensive experience in HEOR, having worked in managed care, pharmaceutical, and medical device organizations. Our final speaker is also today's moderator, Dr. Michael Broder, president of PHAR. He has conducted dozens of expert panels on a wide variety of topics. In addition to being an experienced health services researcher, he is a board-certified physician and provides clinical expertise for many studies at PHAR. And now, without further delay, I'm pleased to welcome our speakers to join me.
Hi. Welcome, everyone, and thanks for joining us. We have, I think, a presentation that I think is going to be interesting for you all today. The 3 of us have worked together on a number of real-world data analysis studies using Medicare data. And as Sydney said, I'm a physician and researcher. Eunice and I have been working together for more than 15 years doing real-world data analytics, and we've conducted hundreds of studies using various types of real-world data. And as I said, and you'll hear about, the 3 of us have worked together on several projects using data from Medicare. So let me just, I'll dive right in, and I'll tell you what we're going to cover today. The first thing is I'm going to talk about some background at a high level about Medicare, the program, and the different types of data that are available, and give you some of the ways that I think about the differences between the types of Medicare data and why we would select one versus another. And then we'll talk about the application process, which if you've ever used Medicare data, you know is not necessarily the simplest thing. And then we'll transition to talking about some of the studies that 3 of us have worked on together that use Medicare research files. And then we'll give you some tips and tricks. And finally, we'll try to leave 10 or 15 minutes for a Q&A at the end. And if I see questions that pop up along the way, I'll try to answer those as we go. Otherwise, we'll get to them when we get to the end of the presentation. So first thing is Medicare itself. So there are 4 main parts of Medicare. Parts A and B are sometimes called original Medicare, and those were the parts created in 1965 by an act of Congress as the federal insurance program for the elderly in the United States. Part A covers hospital care, and Part B is most of the care that's provided not in a facility, so in an outpatient setting. And then Part C actually was authorized in the 80s, but didn't begin to take off as something that people were really enrolled in until the early part of the 2000s. And it provides coverage instead of Parts A and B for people who enroll in private plans. And the idea was that it could provide services that regular Medicare didn't provide in exchange for capitated payment from the government. The idea when it was created was that it would save money by this capitation. Interesting side note, I don't think it ever has saved any money in any year. Part D is the prescription drug coverage, and prior to Part D, the use of Medicare to do real-world data studies was a lot less interesting to people like myself who work in the pharmaceutical industry, because pharmaceutical companies are interested often in what drugs people are taking, and so without that information, it just was less useful. But since 2006, let's say 2010, after a few years of data had been brought in, the Medicare data became much more useful to researchers like me. There are a few main reasons why we like using data from Medicare to do real-world data analysis. The first one is the sample size is huge. We have 65 million enrollees now, and most of those, 57 million, are qualified on the basis of age. Some people qualify for Medicare because they're disabled. For most of our studies, we would exclude people whose primary reason for Medicare was disability, just because it's a very different group. But it is absolutely still a useful group to have. Particularly, there's particular kinds of studies or in certain disease states where that would be the biggest area of interest. For us, it's just been mostly people who qualify by age. And there are 50 million people covered by Part D at this point. So that's a massive plan. That means that you have lots of patients and to analyze. It's also nationally representative, and in a way that commercial claims data really can't be. So almost everybody in the United States uses Medicare once they hit the age. But I will say on the question of representativeness that there is some concern at this point that the data that we're analyzing in Medicare is less representative than it used to be. So on the right, you see this figure that shows enrollment in Medicare Advantage or Part C. And that has steadily increased since the early 2000s to the point where last year, 48% of enrollees had Medicare Advantage. And the reason that matters for the representativeness is that people who enroll in Medicare Advantage are systematically different, probably, from people who don't enroll. If they were missing at random, it wouldn't be so bothersome from an analytic perspective, but it's probably not random. And as I understand it, one of the main differences is that they appear to be healthier when they enroll, but they appear to be sicker after they've enrolled. And the suspicion there is that Advantage plans do a better job of coding conditions, not that people get sicker by enrolling in those plans. Nonetheless, though, this is becoming something of an issue, and I'll talk a little bit later about some Medicare Part C data that are available for analysis. The other thing about these data is that they're very longitudinal. Once people enroll in Medicare, they really don't leave except when they die. There's some movement back and forth between Medicare Advantage and traditional fee-for-service Medicare, but it's very little. It's a percent or so every year. Although about 10% of people change plans, but moving from Part C coverage to Part A and B coverage is very rare. Their data are also very complete when it comes to deaths. So we know who's in the data, and we know they stay a long time, and we know when they die. Medicare data also provides nearly complete coverage from every setting. So everything from home health care to hospice to hospital to outpatient, it's all there. Some things, of course, not covered by Medicare are not in the data, like glasses or hearing aids. Recently, this is relevant for the recent pandemic, vaccinations that, if somebody gets a vaccination in a drugstore or grocery store, that may not be in these data. But for the most part, all the care that seniors get is here. And finally, it's linkable to other data sources, and I'll talk about that a little bit more in a moment. The main kinds of data that we use at PHAR, and as I mentioned, we're a real-world data analytics shop. So this is sort of what we do all day long, every day. But the main files that we use are the LDS and the RIF files. And LDS is limited data set and RIF is research identifiable. The main difference is that the identifiable part. So in RIF, beneficiaries all have an ID number. And that's that we can actually access that number in RIF files. In fact, you could get Social Security numbers if you went through the proper channels and had a reason to do it, which we never have. But the reason we use these files is because both have information at the beneficiary level. So there are other sorts of Medicare data like public use files that are aggregated. But to do the kinds of studies that we want to do, looking at comparative effectiveness or treatment patterns or even epidemiology studies, you want beneficiary level information. And so that's what both of these files provide. The difference, though, is that so that research file, as I said, is identifiable, and so it has more access controls on it. It's also a lot more expensive, takes longer to get, and taking longer to get is for a number of reasons, which I'll dig into in a little bit, but partially because you have to go through this privacy board process because it's considered identifiable information. It's also another difference is that the limited data set files are shipped to you on a hard drive that you then use at your location, whereas RIF in the last few years has gone to this process where the data are available only in this virtual environment. And maybe Eunice, you can say a few words about what that environment is like.
Yeah, the virtual, the VR, they call that VRDC's Virtual Research Data Center. So basically, it's a server, and all the users have to log into that server and conduct all the analysis there. Once they approve your study, they will extract data and then leave those data in your account, then so you can access it. The data center, they have SaaS, so you can analyze your study. And also recently they add Python. Besides that, they also have a Microsoft Office, like Excel, Word, we can use. Very easy to use, and their technical support is really good. However, each analyst will need a seat in that server, and each seat, come with a fee. So that's extra fee on top of the data access fee, you have to pay. And they can be paid quarterly or annually, depends on how long you will need to access the data and the data center. And also another thing about that is you cannot just download the data. They put the data there, but doesn't mean you can just take the data out, download data. You can only download the aggregate result from the data center. And also you have to go through some kind of review processing. They have to review the result, whatever things you plan to take out from the server. They have a several rule you have to follow. And then once they approve, then you can download your result. And the review process usually take up to 3 days. And they have a limited number of the review you can do. It's not like, every day I send up 10 review, something like that. They have some limitation. So you just have to plan ahead. Like, they will take a little longer to do the data analysis compared to using other data set.
Great, thank you. Yeah, so it takes longer to do, which is it's just important to keep that in mind when you're doing the work and trying to plan for how long it's going to take to do something. And we'll come back to some of these other issues in a moment. I mentioned the potential linkages with the research files, and here's some of the more common ones. And so, as I said, the reason you can do this is because in RIF, you actually have a patient identifier that can be used to link out to other data sources. So SEER, cancer registries, this is an important source of information. So when you do studies using SEER Medicare, this is what you're using. The Medicare Current Beneficiary Survey is another one that people are familiar with. And this is just some examples. There are other, we're looking into a data source now that's a linkable data source, the Health and Retirement Study that has a number of surveys of older people, and it seems like a great resource to be linked to Medicare. The way the files are delivered is in what's called standard analytic files. And so I'm just going to talk a little bit about how the LDS and RIF datasets differ in terms of which files are available, because there are some differences. So when you use a limited data set files, you're mainly getting information from parts A and B of Medicare. There's also enrollment information and things like that, but it's sort of hospital-based and outpatients, and it's a pretty comprehensive look at care of Medicare patients. When you add the research files, you have the ability to use Medicare Part D information or the prescription drug file. And so without this, the studies become much more limited in what you can do. You can certainly look at disease progression and mortality and other things like that using a limited data set, but you can't really look at treatment other than the parts of, certain kinds of treatment are available outside of Part D, like some chemotherapies and drugs given in the hospital to a certain extent, but most of the drugs given, oral drugs and given as outpatients, are in Part D. So without getting the research file, you can't get any of it. The interesting thing, though, is the limited data set now comes in two flavors, the 5% and the 100%. And and this 100%, I don't know that we've ever used it. There used to be a 20% sample that we had used, but in the 5% sample is interesting in that, so 5% includes parts A and B and all of Part B. But when you use the 100% LDS, you're only getting part of Part B. So here I'll show the actual standard analytic files that you get and explain why that's important. So in this LDS 100%, there's a master beneficiary file. There are these all the Part A files, and then these files from Part B, so outpatient facilities and home health. But what you don't get in this 100% LDS is you don't get the carrier file, and also you don't have the durable medical equipment file. The carrier file is the most important one in a lot of ways because that's outpatient doctor office visits. And so it's, the 5% sample can be quite useful for doing analyses. We haven't found use for the LDS 100% yet, because by the time we're wanting 100% of the data, we want the drug information as well. There's a difference at the variable level also between these different types of data sets. As I mentioned, the beginning research identifiable files are beneficiary level with a unique beneficiary ID number, and they're also linkable to non-CMS data. Another interesting feature that we've found useful is the ability to have the full zip code. So when you're looking at geographic analyses, and one of the studies that we'll talk about later did use that, and you want to know something about the very specific place where the beneficiary lives, you can use the zip code as opposed to county level information that's available in the limited data set. And then actual date of birth. And as many of you probably know, age, even in months, is a powerful predictor of mortality. And so age in years, which is what you have in a limited data set, is really just not as good. Used to be the case that the death information was much better in the research files, although I see in preparing for this presentation, I see now that it's 96% in the limited data set. So that's not much, that's not so much different. But and race is available in both. In terms of the data lag, the way I think about this is that data lags about 2 years. Now, this says available with a minimum of 14 months, which is actually technically true. But right now it's 2023 and you can get 2021 data. And so that's why I think 2 years is a simpler way to think about it. The way the 14-month lag works is that if you apply at exactly the right moment, so in November of this year, for example, you'll be able to submit an application to request data for 2022. And if the wind is in your sails and it goes through the process easily, you'll have that data in the early part of 2024. So that would be 14 months. And these data files are 99.9% complete. These are mostly what we use when we do studies with Medicare. So you get a full year of data, and you're confident that all the information is there and that it's easily analyzable in traditional ways. If you need something that's very recent, or a new drug approval and the data it hasn't been in use for too long, and the numbers are small, you can supplement these annual files with quarterly files available with only a 4.5 month lag. So that's a quarter plus a month and a half of adjudication time. And now you can request files even right now through the end of 2022. So you could conceivably do a request to get annual files through 2021, and then the 4 quarters of 2022, and you could do that right now. And the way that differs from the annual file is, one, it's charged differently, but two, it's just not as complete. You can see 93% versus 100, nearly 100%. And what's missing there is information from the hospital. So if what you're looking for is hospital discharge information or utilization or cost information, then that's not as complete in those quarterly files as it could be. This is the timeline, sadly, for the RIF request. You can see it says 6 to 8 months from application to data access. And that application takes some time to put together. So to do that application, you have to have essentially a statistical analysis plan or a really thorough protocol in addition to IRB approval. And that packet is what's submitted to ResDAC, or the Research Data Assistance Center. That's the contractor that handles data for Medicare. And ResDAC reviews that. They look at your protocol. They make sure they believe that you can do the study that you say you're going to do, and that you've described it in enough detail and have asked for the right files. And if they buy all that, they will pass that on to the privacy board. And you can see here, this privacy board is months long. And that's the step where they're reviewing your documents to make sure that you're going to keep control of the information and you're going to use it properly in the way you said. Once the privacy board approves your application, they'll send you a notice with an invoice. You pay the invoice, and about a month later, the data are put into the virtual data center where you can access them. Requesting LDS data is simpler. There's a lot of steps that you don't see here. The main one, though, is that privacy board review. There's none of that at all. Actually, these requests go directly to CMS, not to ResDAC, that contractor. And so these requests are handled in a much more expeditious way. You still have to sign this data use agreement that says you're going to use the data the way that you agree. You're not going to try to reverse engineer it and identify patients. That's one of the things you're not allowed to do with a limited data set. And then, so 4 to 8 weeks from submission to receipt of data. And you don't need to do that IRB step at the beginning. So that's another savings, not out of this 4 to 8 week timeline, but it's another savings of time.
And I want to add a little bit things about the difference between the LDS and the RIF file. The LDS, if you request 5% sample or 100% sample, they just send you everything, like a 5%. But for the RIF file, the research file, you have to tell them what cohort you want. You give them the selection criteria, like certain disease you are interested in or something. You have to tell them. So it's not like they will put like 5 years data there for you to access. It's like a cohort base. So you tell them what you want and how long the time frame, they will put data there. I just want to kind of emphasize that.
Mm-hmm. Yeah, thank you. That's a good point. Okay. So now I want to turn things over to Mitra, who's going to talk about some studies that we worked on together using the Medicare 100% RIF data. So,
Thanks,
Mitra.
Michael. If we can go to the next slide. So a little bit of background that IPF, or idiopathic pulmonary fibrosis, is a pretty rare disease, and it's about 14 out of 100,000 people that get this disease. It's chronic lung disease, and it progresses to death. Usually it affects white males that are older than 65 years old. And currently there's 2 novel antifibrotic therapies, pirfenidone and nintedanib, that were approved in October 2014 at the same time by the FDA. And these 2 drugs have been shown to slow the decline in the lung function for these patients and actually reduce the risk of death in a pooled data set that we had looked at. So first, wanted to look at the diagnosis and unmet needs of this special population, looking at pulmonologist visits and CT scans and very specific information that we needed So we did a treatment pattern study initially to figure out diagnosis, where the centers were, where the patients were located, and that study was published. Then we wanted to compare the two drugs and differentiate to see if pirfenidone or nintedanib had greater benefits, whether it was the side effect profile or healthcare resource use or cost. So the second study we did was a comparative effectiveness research. And then the last study was a historic comparison of treated versus untreated patients. So we took the same patient and followed them from 2014 to 2012 to before the drugs became available in 2014, and then followed them if they started to initiate therapy from 2014 to about 2017. And these were all patients with IPF from the Medicare RIF files that Michael just described. If we can go to the next slide. So how do you decide which one of these files you want to use? First, you have to figure out if you want to do a real world study, if that's going to meet your parameters, using insurance claims. So, the Medicare database is obviously insurance claims billable. So primarily, does this affect older population? Because it's usually 65 and over or disabled population that are included. Do you want a long observation period? Do you want to follow them for a certain length of time? So for IPF specifically, the patient's survival was about 3 to 5 years after diagnosis. So we wanted to follow them as long as possible. And sometimes with commercial databases, you can't do that because they fall out after 2 years. And the mortality was definitely an outcome of interest because our patients were progressing to death. So since the death index is tied into the Medicare population claims, that was a benefit for us as well. And again, this is a rare disease, so sample size was crucial in doing our comparative effectiveness research and also the treated versus untreated, so we could see statistical significance. So when you can answer all these questions, and most of mine were yes, we went to the Medicare database, and also we wanted to look at the pharmaceuticals that were out there. So we needed the Part D section with the RX data. Is this identifiable? Do we need identifiable data? So we were actually looking for race and social determinants of health. So these are factors that, pharmaceutical companies are interested in, such as health equity and socioeconomic factors. Another thing that Medicare provides, you can actually link it, as Michael mentioned, to SEER data, if that's applicable to your disease. Or, sometimes you can link it to clinical studies, which we haven't done. But again, there's also Medicare Advantage available, but that's a little bit more limited than the fee-for-service files right now. And again, it's a rare disease, so it didn't require the LDS files, but we went with the RIF files, as was described before, what the differences were in these files, especially the Part D requirement. If we can go to the next slide. So some of the methods, I think I already described. We were using retrospective cohort studies, like Eunice said. That's the requirement. You have to be very clear on what you're asking for, and don't limit yourself to a very specific population, because you can't really go back and ask Medicare. It'll take another 3 months to get your data set. And we also looked at claims from 2010, since they were available. And at the time we were doing the study, the end of the time period was about 2017. So we looked at multiple cohorts, including the treated versus the historic control before the antifibrotics became available. And also we wanted to look at pre-diagnosis, because a lot of times patients with IPF, the physicians are watching and waiting them to see if they progress, and if they can see the scans in their lungs to see if there's honeycombing, et cetera. So those are important factors to consider depending on your disease. Other relevant study measures are, like I mentioned before, demographics. It's mostly a white male population that we had. The disease severity, are they going to the hospital a lot? This is a respiratory disease, so they do have a lot of hospitalizations and, like I said, mortality. Race was pretty much a factor. I mean, you want to identify and stratify what differences in race are from health equity issues, and then the distance to the IPF Center of Excellence to see if that was an access barrier for these patients. And then other outcomes of interest were healthcare resource use and cost, time to hospitalization and death. Like I said, when we were comparing the two products that launched at the same time, you want to be able to differentiate somehow and say if one is costing the system less money or reducing healthcare resources. And then from a statistical analysis perspective, we use propensity score matching 1-to-1 on baseline measures. So that's a pretty good methodological method in order to compare the two populations and have statistical significance. As well as for the mortality, we were using Cox proportional hazard regression analysis that Eunice can probably describe better than I can. And we also use the negative binomial regression analysis for the hospitalizations. I don't know if Eunice, you want to add anything for the methods?
No, I think I just want to add a little things about the processing of getting the data. As Mitchell kind of mentioned, we did a lot of study surrounding the surrounding IPF. So we actually went back to the Medicare to request additional data. So as Mitchell mentioned, in the beginning, you better make the objective a little bit broader. And so that's how we can go back and say, oh, we need additional data. We need historic data. Definitely take a little bit more time to request that. But it's much shorter than, you redo everything from the beginning. So I think that's very important. Like when you put down your objective, it's not like vague, but make that broad. As broad as possible. So later, if you want to do some additional things or whatever, you can go back.
Great, thanks. And we can go to the next slide. So here are some of the results. These are two different studies. So the first one I mentioned was the treated versus untreated population using historic controls. And the lighter blue you can see has better or less severe mortality over time than the untreated population. So that we did have statistical significance and a pretty robust sample size in order to do this analysis. And we looked at over 30 months of this population. And then to the right, you can look at the risk of hospitalizations. Like I mentioned, respiratory hospitalizations are very prevalent in this population, and they do actually lead to mortality sometimes. So again, pirfenidone was the lighter blue color and nintedanib was the darker blue color. And we did see some advantages for pirfenidone over time for 15 months for hospitalizations. So these are two separate studies that have been published, and we'll share the references later. Next slide.
Great, thank you. That's great. Yeah. So thank you, Mitra and Eunice. So we wanted to also cover some of the things that we've learned doing this process and that you might not know. Most of the information, and you can look in the handout section and of this webinar, and also we'll be making some other information available after the end of the webinar. Some of this stuff, a lot of it actually is available on the ResDac website or the CMS website, but some of it you only learn the hard way. And I think both Eunice and Mitra mentioned the first two items that are on this list here about keeping the request broad enough to encompass the areas of interest, but specific enough to indicate that you have the technical knowledge to complete the study. So you are having to convince these reviewers that you know how to do what you're doing. And if you're very vague and just say, we want to compare mortality between these two groups, they're going to reject that application and come back to you and ask you to answer more questions. And it's not unusual to have questions come during that part of the process, during the ResDec review for the RIF files. But the more you can do to circumvent those questions, to preempt them by giving enough detail up front, the better off you are. Sales suppression policy. Yeah, this is another thing that it's easy to forget that you can't present any information on using the identifiable Medicare information on cells size smaller than 11. And, this is to protect the privacy of the beneficiaries. But 11 is easy. It's easy to know what 11 is and how to count that. But what they also count is if you have a column of numbers and you just have one cell that's too small, and so you just blank it out, that won't be acceptable either, because you can add up the other numbers in the total and know that and calculate that. And the other thing that people don't necessarily remember is that measures like median or 50th or 75th percentile or 25th percentile are actual individual measurements. So you usually can't report those numbers either. There are obviously other measures of central tendency and spread that you can report, but those are a couple you can't. And then second from the bottom, follow up with ResDec about timelines. Honestly, I think this is the thing that we have, especially as I said during COVID, we really noticed that things were just getting lost. We expected something to come out of the process, the application process at a given time. We knew it was in that part of review, and then we just didn't get it when expected. And so we checked in and they said, oh yeah, that was, didn't make it into the queue for this section, just sort of didn't happen. I mean, they're only people, so it's a good idea to keep, and mostly very responsive via email. So it's a good idea to keep an eye on things as they go through. And then Eunice, I think you mentioned these things, but anything else?
No, I think that's that's a major thing. Yes.
Yeah.
But I would like to say their technical support is really good, and also even though the reviewing or the application process is long, but when you check with them, through the email, they respond email pretty quickly. They just say, "Oh, didn't make it. Oh, it take longer," but they will get back to you. So. I would say that's kind of plus.
Yeah, I agree. They are very responsive. Yeah. Well, perhaps not surprisingly, the people at this webinar seem like they're pretty likely to be planning to do some studies.
Even with the challenges. But
yes. Yeah.
It is like very robust data set.
Yeah, I agree absolutely. And in fact, one of the things that I was going to say that I didn't say earlier was that I did mention, some of the advantage of using Medicare data, but one of them is the publication advantage. It's much easier to publish a study that uses Medicare than it is to use a commercial claims data source. Even big claims data, the level of face validity when you submit a manuscript that's done using Medicare data is just much higher. And even though, as I said, we've been working, Eunice and I have published, 300 studies using commercial claims. But yet still, you will have reviewers that just aren't familiar with what that even means. I mean, they don't conceptually get where that data come from, especially clinician reviewers. But every doctor and every reviewer of every clinical study that we've ever submitted, they know what Medicare is, and they believe that the Medicare claims actually represent care delivered to the beneficiaries. So let's go to the next, and maybe I'm going to turn off those slides, and we'll go through some questions. Let's see. We have some. So one question was, can CMS Medicare be linked to private Medicare supplemental databases? And the answer is yes. In theory, it can. I've never done that, but the linkage process is one that Medicare takes a pretty agnostic view about. if you can provide the data security, then you can probably do it. It doesn't mean that there's an easy path to doing it, but it is definitely something you can do. Oh yeah, okay, this is good. I didn't mention this, but I wanted to, which was about Medicare Part C. So Part C data are available for research. The important difference is that there are no costs in Part C data. So they call it Part C encounters. It's not really claims. It's submitted by the companies that run those Medicare Advantage plans, and they are required to submit that data to CMS now. And the process takes longer, I guess, because it doesn't go directly from a provider. It goes to those plans and then to CMS. And so available now is data on Part C from like 2015 through 2020. And it is not quite as frequently updated. Like we've seen it. My understanding of the process now is that CMS intends to make Part C data available for researchers because, as I mentioned at the beginning, that's a sort of threat to the validity to your ability to interpret studies using Medicare claims. And so they do intend to make that available, but right now it lags quite a bit, and it isn't even clear that it's going to be updated on the same schedule every year. So unlike in the fee-for-service Medicare, where I told you, 14 months to 2 years, you really can't predict when the data from Part C are going to be available.
There's one question about, does RASDAC ever reject applications?
Well, we've never had an application rejected. I suppose they would, though. Well, interestingly, the first time we did this, we started to look into this more than a decade ago. And at the time, Eunice is smiling because she didn't believe we would be able to do it. So at the time when we did this, what we heard was private companies, non-academic institutions couldn't get access to the RIF data. And, we poured through the materials online and it never said that anywhere. And I had my attorney reach out to CMS and ask, and there was no real prohibition on anybody getting it. It was just, you have to go through the process. And so we went through this process doing a very rigorous application, and our first application was accepted. I think that I suppose they might reject if you don't describe a project adequately, but I think more likely they'll just keep coming back to you with more questions.
And I want to add, for that study, actually at that time, they don't have that data center. So we did get the physical data from them, but we have to jump so many hoops, and the data security is really, they have a lot of rule about that. But that's a long time ago. That's really a headache. But we did get the data.
And somebody asked whether you have to publish the research, which I don't think that's a requirement. You have to share it with them if you're publishing it. You have to tell them about it. I think when you get to LDS, you're asked to submit the publications, but they don't do anything about it. But I think with RIF, you have to send them the publications. I don't think if we didn't publish it, there would be any problem. So somebody asked, can we request 100% RIF if one of our objectives is to analyze prevalence and incidence? And the answer is yes, but the CMS will want you to do the data wants you to do your study in the least invasive way possible. So if that study that you're talking about with incidence and prevalence is doable in the LDS, they probably will suggest that you do that and might send your application back to do that. It certainly happened to us once where we applied to do something without explaining how uncommon the condition was. And then this was before the 100%. There was no LDS 100%. And then we went back and showed epidemiologic data showing that it was uncommon. And they said, yes, you've shown that you can't do it in the 5% sample. So yes, you can have access to this 100%. But in terms of prevalence and incidence, like for example, if to identify the patients you need Part D, then that would be an argument for using RIF. If you don't, then you might be asked to do it in LDS. Are there restrictions on how the data are used, like for promotional use by a pharmaceutical company? Yeah, you can't do that. Well, okay, so you can, if you have a published study, you can use that the way you could use any published evidence, but you can't, there are restrictions on commercial use. And what I believe the CMS means by that is you can't sort of create a tool out of the data, even the LDS data. You can't do it. I mean, obviously, you can't do it in RIF data because you don't have the data, but even in LDS, you can't do it. But once a study is published, you can use it in whatever way you see fit. What else? Carrier file. Oh, okay. So to clarify, the carrier file not available for the 100%. That's only in the LDS. In the RIF, you get the carrier file. Yes, absolutely. So when you apply for those research identifiable files, you get it all. It's only in the LDS 100% that you don't get that carrier file.
Yeah, because it's too big. Mainly is because too big. They ship you, for example, like I say, 5%. They just send you. That's a standard data set they have. Once they approve, they just send you the 5% sample for all the data tables. For the 100%, you make 100% of carrier file is huge. So that's why they don't do it.
Yeah. Durable, somebody asked about durable medical equipment. Yes, that information is available in DME. There is a file, durable medical equipment, and that file is available both in the LDS and RIF. DME is interesting in that for many studies that we've done, you do find things in that CMS data that you can't get in commercial claims. So that medical equipment's usually only given once. And as Mitra mentioned, the claims run out in commercial sources of data are usually only a few years. So if you got something 5 years ago, you can't find it. But in Medicare data, you can.
Also, some of the Part D covered oral medication, like some of the chemo medication, was included in the DME.
Interesting. Didn't know that. Thank you. Yeah, there are a couple of other sort of individual questions, and what we'll plan to do is we will answer these questions in the days to come, and try to get as many of these answers as we can. Some of them are not maybe general enough that I want to answer them right now. Is Part D drug data available in either LDS or RIF? No, it's not. Part D, the only way to get Part D information is to do the research file application.
But however, interestingly, for example, like Sears Medicare data, if you go through the Sears Medicare, they give you Part D. So
interesting.
Other linkage, for other linkage, like Michael showed some slide, a lot of linkage, when they say you can link a Medicare data, they give you Part D. I don't really understand the logic behind it, why they don't give a Part D, like 5% sample to the limited data set, but that's how they do that right now. So
yeah. No, I agree. It doesn't. I mean, the concept is privacy, and it's hard to see how adding that drug data really does anything to, affect the beneficiary privacy. How do we differentiate what's considered inpatient versus outpatient diagnoses based on types of files? Yeah, so in Medicare fee-for-service, the analytic file, that carrier file, is where most of the outpatient physician information is. That's where you're going to find outpatient information, and that's where all the good stuff is in terms of diagnoses and things like that.
And if, for example, like for the inpatient, we call it inpatient table, but actually it's tables. For the inpatient claim, they give you, I think it's a 3 or 4 different label of the claim, and then for the outpatient facility, same thing. So if you're looking for something about the inpatient hospital, then you just looking at those tables related to the inpatient hospital claim, and the carrier file is a little bit different. Carrier file is like a doctor. But so they include a lot of office visits, but as well as some radiologists, for example, if you're hospitalized, right? So you have a hospital bill as well as you have some individual doctor's bill. And those is in the carrier file. But you'll be able to kind of tell by the date and also the service location and to know what happened and when that happened.
Yeah. Okay, I think I have one last question here that I wanted to answer from the very beginning about the death information. So death information comes from a number of sources in Medicare. One is that enrollment, they get information from Social Security on whether somebody's died or not. So that goes into the enrollment file. And the validation, when I showed a slide at the beginning that talked about the proportion of deaths that were validated, and most of them are. And validation in that context means there's information from outside of Medicare to provide additional information that the beneficiary has indeed died. So that's Social Security or vital records or things like that. So that's where that data comes from. And since death is pretty final, we'll consider that the final question. And I would say we certainly appreciate your attendance at this. I hope it was useful for you. And with that, I will hand it back over to Sydney.
Thank you to our 3 expert panelists for being here today. It was a pleasure having you here, and I hope that you all had fun. In closing, we hope you enjoyed this HealthEconomics.com webinar sponsored by the Partnership for Health Analytic Research, and I hope that you enjoy the rest of your day.